Melatonin is one of the most widely used sleep supplements in America, and I routinely see people taking it in ways that either do nothing or actually shift their sleep in the wrong direction. That's not harmless. If you take melatonin at the wrong time, you can delay your circadian rhythm instead of advancing it. And if you take too much, you increase the side effects without actually improving sleep. Most people don't realize that the supplement often doesn't match the label. This matters because melatonin is not just a sleeping pill. It's not a sedative. It's actually a biological timing. So I'm going to show you how melatonin works, the evidence behind dosing, when it helps, when it doesn't help, and the common mistakes I see clinically with my patients. And if you stay to the end, you'll get a better sense of whether you should even be on it or not. And you want to talk about that with your doctor. So what is melatonin? It's a circadian phase regulator, meaning every little cell in your body has a clock in it, and melatonin is secreted by a part of your brain called the pineal gland, and that tells your cells that it's nighttime. So melatonin is not a sedative or a hypnotic drug like Benadryl or Ambien. It's a signal to your cells about what time it is. And remember, the actual peak in your bloodstream, in your brain, is about 0.2 milligrams. It's not a lot that has to go up for melatonin to work. What does melatonin actually do? You might be surprised by this. It doesn't do that much. In controlled studies, we see the amount of time it takes to fall asleep decreases by about 7 minutes. So it's not going to take somebody who's taking an hour to fall asleep and get them to sleep right away. And it increases the total amount of time that you do sleep by only about 8 minutes. So these are fairly mild to moderate effect sizes. So melatonin is not Ambien. So what does it actually work well for? Things like jet lag, when you're flying across 5 different time zones, or circadian misalignment. For example, if you have something called delayed sleep-wake phase disorder and you're falling asleep later and later every time. So that's what it's really going to help people with. So what are some of the mistakes people make? So let's start with the first mistake I often see, which is the wrong timing. So remember, the timing when you take melatonin is more important than the actual dose of melatonin that you take. So if you take a huge dose at the wrong time, that's much worse for your sleep than taking a lower dose at the right time. Melatonin is going to be shifting your clock, shifting the signal of what time it is in your own brain. It's not going to override insomnia per se. So for somebody who actually has delayed sleep phase disorder, for example, they're going to start taking melatonin about 1 or 2 hours before desired bedtime. And here's something most people don't realize. Melatonin actually has a phase response curve. What that means is that the effect of melatonin depends on you take it. So if you take melatonin in the biological morning, meaning the actual morning and the sun is just coming, it can actually delay your circadian rhythm, meaning you can fall asleep later the next night. And then if you take melatonin in the early evening, it can advance your circadian rhythm, meaning it's going to make you fall asleep earlier. So timing is not neutral. It can move you in opposite directions. That's why taking it casually, you come home from work or whatever, and you just say, all right, well, right now I'm going to take it 7 o'clock. Tomorrow I'm going to take it at 11 o'clock. Without really thinking about circadian timing, it can actually backfire. Here's the most common mistake that I see. Somebody, for example, wants to fall asleep at 11 p.m. Their body's internal clock is closer to 1:30 a.m. or 2 a.m. So they start taking melatonin at 11:30 p.m. That's way too late to meaningfully shift the biological clock earlier. So at that point, they're not really advancing their rhythm. They're just hoping for sedation. They want to pass out. And melatonin is not so good at that. Now, on a more practical note, in terms of safety, melatonin can cause a lot of drowsiness in some people, especially at higher doses. So as a general rule, you should avoid taking melatonin within 8 hours of an activity that requires some sustained attention, like driving long distances. Unfortunately, people often think of melatonin as very benign. Oh, it's just melatonin, just take that. It's generally safe compared to, for example, a benzodiazepine, but it's still biologically active, and you got to think about that. So that's timing. Now let's talk about dose, because this is where things get even more distorted. Typically, if you go to the pharmacy, you're going to see bottles of melatonin with 3 milligrams, 5 milligrams, 10 milligrams, even 20 milligrams. I sometimes can't believe this when I'm in the pharmacy. But physiologically, like I said, your body's natural nighttime peak is very, very small. It's like 0.2 milligrams, the peak of melatonin. So many people are taking 10 or 50 times the physiological level in their own body. And we don't really know what that's doing. Many people are supposed to actually start melatonin at 0.5 milligram or 1 milligram, and then only carefully go up under supervision. And if someone's using melatonin for circadian rhythm shifting, which is what melatonin is actually best at, moving the sleep onset time, a number of studies actually show that lower doses, often 1 milligram or even less, if it's an immediate release melatonin, are sufficient. So more is not necessarily better. Higher doses don't reliably produce greater phase shifting. So keep that in mind. And remember the big picture. According to one meta-analysis, a study of studies, you look at all these studies on melatonin. Melatonin is going to decrease sleep latency, how quick it takes to fall asleep, by 7 minutes on average. And it's going to increase the total amount of time somebody's sleeping by 8 minutes. It's fairly mild. And the other thing in terms of overdosing is when you go above 3 to 5 milligrams, the relationship between dose and effectiveness is not linear. So you're not really getting much benefit above 3 to 5 milligrams compared to just taking 3 to 5 milligrams. So if someone's taking 10 or 20 milligrams and expecting a dramatically better result, the evidence does not support that. So you got to be really careful with dosing. And for people who do take really high doses, systemic reviews of what happened, for example, at 10 milligrams or above, we see all kinds of adverse effects, negative effects, drowsiness, headache, dizziness. It's nothing catastrophic. It's not life-threatening, but it's quite unnecessary. And imagine, especially for vulnerable elders and such, it's going to be a problem. Another issue that many people don't realize is supplement variability and what's actually in the supplement. So a 2017 study in the Journal of Clinical Sleep Medicine, for example, analyzed the over-the-counter content of melatonin in supplements. And what we see is that the actual melatonin content ranged from 83% below what the label actually claimed to 478% above what the label said. So you never really know what you're getting. Because remember, the supplement industry is not regulated like the medication industry. And melatonin in the pharmacy is a supplement. And many of these products also have other stuff in them, serotonin contamination, etc. So quality control can really vary, and you got to make sure you know what's in your gummy or whatever you're taking. So what do I recommend to patients? Well, I typically say go as low as you can in terms of dose. Start very low, 0.5 milligram, 1 milligram to start. Most of the people I know, adults, don't need more than 3 milligrams. So when I see somebody on higher than 3 milligrams, 10 milligrams, even 5 milligrams, I'm getting a little suspicious of what's going on. There's very little evidence supporting more than that. The other thing is if someone's taking it every single day, a light bulb goes off for me because you really shouldn't be taking it every day unless you're doing around the world traveling constantly. And there's very little evidence supporting chronic nightly use above 5 milligrams, especially when the doses are higher. It doesn't really make sense. The other thing is, even if your dose is fine and you're using it for the right amount of time and you're using it at the right time, you could still be using it for the wrong problem. So this is another issue, the wrong problem. Are you using it for the correct problem? Remember, melatonin works best when the issue is circadian misalignment. It's not really going to work well for anxiety-driven insomnia, cognitive rumination, where you're trying to fall asleep and your whole day's stressors are going through your head, or you wake up in the middle of the night and you can't go back to sleep. That kind of thing is tough, but there's other things you can do for that. And melatonin is not recommended as a first-line treatment for chronic insomnia. If you look at the American Academy of Sleep Medicine, what they recommend, it's not for that. But many people believe it is. So what can you do if you're having those kind of situations? Well, there's something called cognitive behavioral therapy for insomnia, CBT-I. This has been studied quite systematically, and it has larger effect sizes than melatonin, meaning the effect of using that technique for sleep, especially for rumination, anxiety-driven insomnia, waking up in the middle of the night, the effects of that are much stronger, both in terms of how long it takes someone to fall asleep and how long they can maintain their sleep. And whenever you do see medication studies, you have to also remember they're just literally giving people a pill. They're not optimizing sleep hygiene before that. So we don't know the potential of what could have been done otherwise and how needed that pill really is. Now, there's one more category of mistakes I want to address because this one involves risk, and this is glucose metabolism. So melatonin actually interacts with your glucose metabolism and your insulin signaling. There's some research showing that melatonin can impair glucose tolerance in certain vulnerable individuals, especially depending on genetic vulnerability and genetic variants in the type of melatonin receptors you have in your brain. It doesn't mean that people with diabetes should never use melatonin, but it does mean that it's not metabolically inert. So you have to watch out for what's happening with glucose and insulin when you're on melatonin, especially more than once or twice. The other thing is everything you put in your body has a medication interaction potential. and melatonin's no different. So there's some reports of increased bleeding risk in patients taking a medication called Warfarin, which is a blood thinner. So you got to watch out if you're on a blood thinner. It may also influence blood pressure in people who are taking anti-high blood pressure medicines. And there are a couple case reports suggesting some caution in epilepsy or seizure disorder. So again, nothing panic inducing here, but it's not something you can just ignore. You can't just think of it like candy. A lot of questions I also get are relating to kids and pediatric use. So melatonin use in kids has dramatically increased in recent years. This is unheard of 20 years ago, but it's true that low dose melatonin can be effective for very short-term management for insomnia in kids. But long-term safety data, especially beyond a few years, is very limited. We just don't know what the long-term effects are, and the long-term effects on development, the kid's endocrine system. It's just totally understudied, unknown at this time. Doesn't mean we have to be afraid of it if you have to give melatonin to your kid once or twice here and there at a very low dose, but we have to use melatonin very thoughtfully. The other category, of course, is pregnancy. So if a woman is pregnant, melatonin is biologically active. It crosses the placenta. We know that, but we don't want to use melatonin casually without thoughtfulness and without medical supervision. We don't have enough data about pregnancy either. So in summary, think of this as 3 main principles. Use low doses, usually between 0.5 milligram and 1 milligram, 2 milligrams. I wouldn't go above 3 milligrams generally. Make sure you really focus on the timing of melatonin use, more important than the dose. So early in the evening, if you're trying to advance your circadian rhythm, and make sure you're using it for the right problem, which should be circadian misalignment, not stress-driven insomnia, ruminations, anxiety-driven insomnia, chronic insomnia. Keep those 3 things in mind. And if it's not working for you, if melatonin is not really having the effect you're needing, it may mean that you're using the wrong tool. It doesn't necessarily mean you need more. It doesn't necessarily mean you need a higher dose. So I hope this has been helpful for you. If you know someone who's struggling with insomnia, pass it on. Feel free to join my free newsletter where I provide evidence-based insights without any fluff or hype. As you can see, we just stick to the facts here.